two good points. The other group talked about taking a look at labs and vitals, and I do think that those are important, but some of the things that I think we could put a little bit lower on the totem pole when it comes to transitions of care. So in terms of the things I wanted to discuss with you, as already stated by Group 6, doing that full medication reconciliation. And when we talk about coming from the home into an ED or a home into a hospital admission setting, that's somewhere where I want all of your minds to go. Is a med reconciliation is definitely one of the first processes to getting a patient admitted to the hospital appropriately. And so no matter what, if you're in an ED setting, I know for anyone who has possibly had some time to spend with an emergency department pharmacist, I know that this is one of the crucial things that they're trying to get done. There are even some institutions that are using pharmacy technicians to do this task now. Some of the higher functioning certified pharmacy technicians will do med recs on the patients to make sure that they have a sound picture, a sound clear picture of what the patient is taking, not only from the pharmacy, but also from the patient. So when doing this medication reconciliation, you likely could find out that he hasn't taken his meds in over a week. Potentially it could be because he doesn't have refills, that's what it states here on the slides, but it could also be for another reason. He just didn't want to take them anymore. His friend told him that they were all going to give him diarrhea, whatever may have you. I've heard the gamut, but patients have their own reasons for stopping taking medications, and you'll only know if you ask. So that's why having a conversation and communicating is so important. Documenting whatever it is that the patient says in the EHR is also important, because if someone says, well, their pharmacy says they're taking these medications, you need to have that documentation that says, well, I spoke to the patient and he's actually not taking any of his medications. So having that documentation is going to be crucial. Sharing information from the caregivers, if any come in with him, with the healthcare team is going to be important, and you want to collaborate with the family. So it could be that he came in with his wife if he's married, and so she could be a big proponent of whether or not he's eating the right things at home or whether or not he takes his medications. So having those discussions with her in the ED are going to be important as well, because if he's as short of breath as he's saying he is, it's possible that he can't really communicate in the way that he needs to. So his wife could be, or whomever, whichever caregiver could be a good proponent of information there. It could be done at this point. It depends on the individual, but giving the patient some additional education about their knowledge about their heart failure. And so if for whatever reason he stopped taking his medication, this could be a good education point for the patient to let them know, hey, these medications are important for this reason. This is what heart failure is doing in your body. This is what these medications are helping to combat. This is why we want you to take them. I heard some rumblings here about possibly converting that tartrate to succinate because it is the studied version, and it's what gives us benefit in heart failure, reducing the morbidity and mortality. And so that's definitely a conversation that can be had with whether that's an ED physician or the team, whoever's admitting the patient. The patient is also a smoker. So one of the things that I didn't hear from either of the groups was this conversation about we're not particularly letting up in the hospital, and if we're trying to get rid of your edema, we're not particularly letting you outside to go smoke. So how do we combat your nicotine addiction while you're in the hospital? And that can be done with nicotine replacement therapy. So starting patches and bringing that to someone's attention, because it could be that the patient is more amenable if they're not actively withdrawing from nicotine while they're in the hospital. And the last thing here is ensuring that there's clear communication to all parties involved. Is there anything that I have not mentioned currently that any of the other groups had that they wanted to discuss in terms of transitions of care as it relates to coming from home and into the hospital setting?
Why would you get it? Because my mother say it's time.
Hearing none, the last thing that I want to share with you guys is something that you likely may not see that often unless you end up practicing at a VA hospital. But it's the fact that sometimes patients can have more than one doctor, and it really happens a lot with our vets. And so when we think about clear communication with all parties involved, that also includes the multiple physicians. So they keep their VA benefits, they go to their VA PCP, but they also may see a regular primary care physician in their community because they just like them. Their medical insurance pays for it. And so that is a place where a pharmacist can have to play a role as well, because you can try to keep those lines of communication open, so that there's not too many cooks in the kitchen when it comes to those medications. Because one doctor might think the patient needs to be on tartrate, and the other one might say, oh, they need to be on succinate, and you can help kind of clear those areas of communication as well. So always considering that a patient may or may not have more than one primary care physician is going to be important as well. So moving on, we're at our next transition. Of course, we did have acute decompensated heart failure. So he's now on the cardiac floor. It's his second day on the floor, and there are discussions of him staying for a couple more days. He's not quite as asymptomatic as we would like, so we're going to keep him in hospital. We have his inpatient medications listed here. We've made some of the adjustments that we discussed in the ED. As you can see, inpatient medications include metoprolol succinate, as well as a nicotine patch, and then we've continued some of his home medications. But the other thing that you can see here is that the furosemide is being given IV. So just keying you into some of the changes that have been made in the hospital thus far. Based off of the information that you guys have available, please take some time with your groups, work through what you have here on the cardiac floor and what you think is important in terms of when he comes up from the ED and he's now on this cardiac floor, what kinds of transitions, what kinds of things may we need to change at this point.
What is an allowed number? Yeah.
What? With nothing to dip in it? Unless you got some nuggets in your purse, put that shit away. Do you have any other snacks though?
I have a little Debbie brownie.
Yeah, but was it your only one? Oh, you had one at home, right? You're going home after this, right? I don't feel bad.
I put my keys in this velvet so that I could just feel for it. But then when I put my gloves in here, they're really cold. They're not velvet, but they're also
When you take gloves, why don't you put your key in the gloves?
But I just have my mailbox key, my car key, and my house key. I have my keys all in here, so it's just the keys.
Why don't you put your keys on you?
I got my oil change this morning and the guy asked me for my oils. And I was like, yeah, I know I have them because I got here, but I thought I don't know where they are, but they're somewhere. I couldn't have gotten here.
What? Your little Debbie is burning my throat.
I already did. Do you need some water?
Yes.
too.
But not the word.
Dang.
I know.
I picked up my purse to begin with to find my chapstick, and then I realized it was so
Where's the check? You remember that video? Well, it was before your time, Kendall. What?
I didn't say anything.
Well, you ask your parents for like a big ass truck.
Yes.
Yes, to match your gun.
I have a gun. I can.
Got a gun. What kind of gun do you get? Yeah, what kind of gun?
An M&P.
What's those bullets you throw?
9 mil.
Oh,
Yes.
I love my guns. I want to go to the shoes with you.
These are so short. They look like chodes compared. Keep scrolling,
Here's
Kendall.
an MMP.
I don't know if it's the 2.0 or the compact or.
That
Hopefully it's the
MMP 380 Shield Easy is what I have, and I love it.
Ooh.
It's so easy to shoot. There's like hardly any kick to it at all.
Mine, the magazine.
Oh,
It's very difficult to get into.
And then
This one looks very green,
earthy.
earthy. Yes, that's the word I was looking for. Like a tree would have that gun.
Yeah.
Can we sort by color?
I don't know. I don't know if you can don't have these sort guns regular. Can you buy the 8+1? Jeez, 16 plus 1.
None of these are blue. This is ugly. I hope you didn't get a silver one,
I did
Kendall.
not get a silver one.
Good.
Mine is black. I was going to try and find the one.
Revolvers.
Is that what you? There's your blue one.
Huh?
Teal.
No.
I think revolvers are ugly.
They are ugly. You all need guns.
Do you have a license? I need to get one. I just don't feel like spending $75 on it.
It's just
I don't
chilling
need
in
it if it's in
my.
my home. But
Wow.
Just so I could show you the one that I have. Stop!
Go to the rifles.
Hang on.
Can you get a rifle?
I don't know about the manual thumb safety or anything like that. There's
This is a less earthy. It's a khaki gun. Looks like grippy. Yeah.
I'm going to ask someone from group 13 to let me know one or two things that you guys identified that can be addressed here.
She's beautiful. Only $500.
So we have that there are persisting symptoms continuing presentation, ensure clear communication between all healthcare professionals involved, assure adequate oxygenation and ventilation, consider nitrates to increase stroke volume / cardiac output, DVT prophylaxis, switch patients' medications from IV to PO if possible to prepare for discharge, and lessen financial burden.
So I missed the very first part of what you're saying. You came back in when you were talking about communication with other providers. What was the first part?
Not that.
Persisting symptoms, continuous cardiac and vital monitoring, appropriate documentation.
Perfect, thank you. All right, so our group 13 gave us a good amount of things that we were looking for. Group 8, is there anything different that you had or that you want to add to the things that group 13 gave us?
No, we don't have anything to add.
Thank you. All right, so I'm going to ask this question. Group 13 let us know IV to PO is something that we want to do. That is one of the things I want to discuss with you guys. So group 11, what does that ratio look like for our IV medication that's available? I just put it up there. I totally shoot myself in the foot all the time. You can still tell me, and I'll still celebrate your answer.
1-to-2 ratio.
Nice job. Which one is the 1 and which one is the 2?
The IV is 1, PO is 2.
Very nice job. So that is one thing that I will ask. I'm not asking anyone to memorize anything from pharmacy school. You don't need to be a walking encyclopedia. But I do know if you get to your APPEs and you're unable to tell someone what that ratio is, it will be frowned upon. So if you want to store that little nugget in your brain for moving forward, I would recommend you do so. So group 13 gave us a lot of great things to think about. One of the other things that I hadn't heard was considering initiating Entresto. So this is a big blockbuster drug that a lot of people are in love with in terms of treating heart failure. And so it could be at this point that that conversation is started. One of the biggest things that you need to be concerned about when starting Entresto in a patient with heart failure is this washout period that comes along with it, especially if the patient has already been on an ACE inhibitor. Now, it's a little different for this patient because he clearly told you he hadn't been taking his medications for 2 weeks, and so his washout period, relatively non-existent. But for someone who had been continuing on their medications, this is a big point of education to give to your healthcare team that there is a washout period that is needed if this medication is started. What I will tell you in practice, a lot of the healthcare teams want to start their patients who have heart failure on this medication. And when it was first being prescribed, a good amount of people were missing this washout period and putting the patient at additional risk for those issues when combining an ARB with an ACE inhibitor. So that's one big transitions of care point that a pharmacist can have with this patient. In addition, we talked a lot about communication with group 13 in terms of keeping those open flows available with the healthcare team and the patient. Communicating those IV to PO conversions, as they stated, is going to be important. So it saves the hospital money. Nobody particularly wants a line in their arm for that long because it can increase risk of infection. And so making that recommendation, especially because as you can see on his inpatient medications, he's taken everything else PO. So I can totally co-sign the fact that we give an IV medication to hit that edema hard and get it fast. But once he's kind of leveling off and he's meeting back to some decent vitals, giving that medication PO is reasonable and it's cost saving and decreases the risk for infection here. All things that we're after, okay? Patient and caregiver education, so I'm sure people will come to visit him and maybe he's even in a better mindset to receive that education as to why his medications are important, or even if the decision is made to start Entresto, what Entresto is, how it acts, what the studies have shown, and why it's important can be discussed with him at that point as well. And then, as always, and as that group stated, documenting everything that you do if you do things. The one thing that that group said that is not listed here, and I think is a really great point that I also kind of heard when I was here in Albany, is that DVT prophylaxis is a thing that can be considered. If this patient is not ambulating, it is important to make sure that he is not throwing clots as he stays at your hospital. And so making sure that he is properly anticoagulated if necessary is important. If he's up and moving, it may not be something that you put on. You may not have to start DVT prophylaxis, but if he is stationary, it's going to be an important part of his transitions, and I'm glad to hear that people were thinking about that.
Dr. Osai,
Yes.
was there a problem with his ACE inhibitor?
There was not a problem with his ACE inhibitor, except for the fact that he wasn't taking it. So if the decision is made to continue his outpatient medications as his inpatient regimen, that's definitely something that the team can decide to do, with the exception of switching the tartrate to succinate as we saw. But there was not a problem with his ACE inhibitor.
Dr. Osai, would you consider supplementing with potassium? I'm not sure if you mentioned that.
I did not mention it, so I think that that's a reasonable consideration. Taking a look at the labs that we have available, what was provided is that he had a potassium of 4.5 the last time we checked. If you find that potassium is wasting because you are giving so much IV Lasix, it would be important to start a potassium chloride supplement if needed. However, it's really going to be lab dependent on whether or not you start that medication.
Did they give him the wrong dose of furosemide, or did they increase it to 80 because he was having edema?
So they increased it to 80 because of his edema, to help get rid of his extra water. That could be postulated. However, in a clinical setting, a team could choose to continue his current dose. When trying to treat his acute heart failure, it could be that they ramp it up for a little while to help get rid of some of that fluid and then back down later. Either one can be done by teams. What other questions can I answer for you guys?
Should this patient be started on spironolactone for the heart failure guideline?
So that's a really great point, and I'm glad to see that you guys are taking a look at your guidelines and optimizing the therapy for the treatment. It could be considered that because of the stage that this patient is in the class, that spironolactone is a reasonable addition to therapy. Now remember, I'm having you guys think this entire case. Look at this patient as a whole. So if you already have this guy who stopped taking his medications for whatever reason, adding on an additional medication to his regimen, let's say we didn't start the Entresto at all. We left everything the same, and now we're saying, should we add spironolactone? It could be that if he's already not adherent to his current therapy, adding on spironolactone isn't going to help him any. So that's something to consider. In terms of treating for the guidelines, yeah, it's a great idea. Stage C heart failure that's still symptomatic can benefit from spironolactone. But stage C heart failure that's symptomatic because of non-adherence may not benefit from spironolactone. So taking all the variables into consideration would help you decide whether or not to start that. Personally, based off of the case and the things that this man came in and told us, I wouldn't think that he's a candidate for spironolactone. Had he came to us taking his medications and still having these symptoms, then it would be more, I would lean more towards starting spironolactone at that time. What other questions can I answer for you guys? So the only other thing that I want to mention here before we move forward is in terms of thinking through, as we did with the IV to PO conversions, always thinking through the routes of the medications that are present. So I specifically built this so that man could be on an IV medication and it could kind of trigger your minds to say, oh, IV to PO is somewhere that we need to go. But I think we may have talked about this briefly last week, and I want to bring it up again. It's at this point where, let's say if a patient came in and they were started prophylactically on antibiotics for a suspected infection, and maybe it's determined that this patient doesn't have that infection. And so making sure that we are de-escalating the antibiotic therapy. Maybe we have back our information from the microbiology lab that tells us exactly what we are looking to treat. So now we can go from broad spectrum to a more pointed therapy. So it's at this point, usually hospital day 2, maybe day 3, where you would be looking to either narrow that antibiotic coverage, narrow that choice, or possibly de-escalating or taking those broad spectrum antibiotics off at all if you determine you don't have an infection. And even in here also going from an IV antibiotic to a PO formulation to help with that prep for discharge. So neither of our cases really focused on antibiotics, but I want to implore you to think that that is also something that can be happening at this case if there was a patient who had that type of infection. Any questions before I move on? All right, so we are currently at the point where he's been in the hospital for about 5 days and it's time to go home. His symptoms of acute congestive heart failure are resolved and he's ready. He's getting on out of here. We have the current inpatient medications. These are the decisions that the team has made. And I want to know what you guys think should be considered in terms of this transition from inpatient hospital stay to going home. What are we looking at for this patient? What kinds of things do we want to do or recommend at this point? Take some time with your groups, discuss, and we'll come back together in just a couple of minutes.
that's what I had. But I just, the commercials got too much. I'm nervous. Should I ask him for y'all? What I say yes.
But it's yeah, just feel like, hey, Brielle really wants to watch Game of Thrones and everything is really happy if I caught up and I have your case go on.
I'm nervous.
I would doubt you would say no.
Nervous.
I can't see you say no. If you probably
Well, maybe that's why I think
I'm scared. Can only like a certain amount of people watch it at the same time? I've already watched seasons 1
I think it's
and 2.
two people and then it'll pick you off. But if you well, I think you have a high, I don't think about them and then we're gonna have a word watch at the same time. But I don't think he's watching each other. His parents are not here to watching.
I'll ask him when mine runs out. I know.
She just found the calendar for like this start
No, I just need an insulin detector. I know, I cracked it like a week within having it.
I was about to say,
I know.
What?
I saw her screen was cracked, but it's just her screen protector. But I'm the one that pays for it.
The basic one.
Alright, I texted him real. Okay. I was like, I can give you my Hulu login. No commercials. They're texting.
Alrighty, so let's bring it back together here, you guys. For our discharge home transition, I'm going to ask Group 23 to share with me one or two things that you guys have identified.
I said to counsel the patient on the changes of his medications to stopping lisinopril, starting the Entresto, and switching from metoprolol tartrate to succinate, and make sure he knows how to take them all. We also said to consider the patient's willingness to stop smoking and counsel him on why it's important.
Awesome. Group 10, one or two things you guys identified. I couldn't really hear you.
Sorry, that mic in front of me doesn't work. We're going to ask the patient about any barriers to medication adherence he might have, like cost or